It's not pinching the glutes together as if you're trying to hide a quarter between your butt cheeks.
Good morning. Happy Tuesday. I have Neuro Coffee in hand and it is perfect. That is really good. Okay. Quick housekeeping. The intensive 14, we have set the dates for the intensive 14. That will be August 19th through the 22nd. We'll probably start application process somewhere late next week or so for that. Remember, we get to choose 8 people to come. So that's how many people fit in the purple room. And it also keeps it very tight and intense, if you will. So again, save those dates and be looking for that. Today's Q&A is with Leo, and Leo had some questions in regards to some hip range of motion measures that he was bumping into with some of his patients, and this led us into the 3 impingement concept. So the 3 impingements of the shoulder, 3 impingements of the hip, very, very similar. For those of you that would like to go beyond today's Q&A in regards to those impingement representations, I have 2 videos on the YouTube channel for those, one for 3 impingements of the hip and one for 3 impingements of the shoulder. So you'll see how those old school impingement tests that we were taught actually become positive, and then some rationale and some approaches as to how to alleviate those situations. So again, I think you're gonna find this Q&A useful today. If you would like to participate in a 15-minute consultation, these are free of charge, by the way. I don't know if I've ever mentioned that. But it's just to help everybody out. So if you'd like to participate in a Q&A, please go to askbillhartman@gmail.com, askbillhartman@gmail.com, and we will arrange that at our mutual convenience. Just remember to put 15-minute consult in the subject line so I don't delete it. Everybody have an outstanding Tuesday. I will see you all tomorrow.
Okay, we are recording. Clock has started. What is your question, young man?
So my question, so I'm pretty new to I guess your methodology of things. So I've kind of picked up bits and pieces of it, just watching what you put on YouTube.
Gotcha.
So there were a couple of short clips that I saw. I think it was a seminar you were doing. I don't know if it was at IFAST, but it was with I believe he was a power lifter. So
yeah, that was here.
Yeah, and so I saw you put him in a couple positions and basically trying to improve. I think it was hip flexion and shoulder internal rotation.
Yeah.
So I guess my question and what I put in the email was basically about, I work in a pretty busy private practice and trying to come up with different ways just to make the exercise intervention, as effective as it can possibly be.
Yes, sir.
So kind of just some big pillars and things that I can have in the back of my mind in terms of positions that can help influence some of the big things that we see in clinic. So like common one in clinic for shoulder issues is usually a very restricted internal rotation. And then typically for the hip is hip flexion, where people come in and they get, a lot of pinchy sort of sensations in the hip. And those are like 2 very common deficits.
Yeah. Okay. Yeah. So hang on. real quick. There's 2 videos on YouTube that are going to be really, really helpful. Okay. And these are the 3 impingement. So there's 3 impingements for the hip and 3 impingements for the shoulder. Okay. And what I do is I go through the old school impingement tests. So the Hawkins-Kennedy, painful arc, and then the end range impingement, because each one of those is representative of a compressive strategy in different areas. Okay. So when you're talking about somebody that comes in with limited internal rotation of the shoulder, like, the positive Hawkins-Kennedy kind of thing. Okay. So under those circumstances, what you're lacking is the early range shoulder external rotation measure, which would fall into the category of say early traditional shoulder flexion. Okay, but it's an ER measure. So when you have a posterior lower compressive strategy, so they have compression below the level of the scapula on the posterior aspect. Okay, what happens is that external rotation that would typically be in this area is now out there. It's away from midline. So the compression takes away that range. So what happens is they're moving into internal rotation where they should be able to externally rotate. So what happens is they literally run out of space as they move up, because this becomes more anterior expansion, posterior compression as I reach into this space, which compresses it even farther. So they literally run out of space. There is no more space for the shoulder to even move.
Okay.
Right?
Yep.
So what you need to do then is you need to restore the ability to expand below the level of the scapula. I got a whole bunch of stuff for that. If you look at some of the, like the better band pull apart is actually one of those exercises that's going to help with that. There's a seated version of that as well. But again, anything that's going to promote the expansive strategy below the level of the scapula is going to allow you to recapture that early flexion. So your hip people they run out of hip flexion, it's the same thing. It's exactly the same thing. Now, you got to start thinking about like where the pelvis is going to be oriented. So in both cases, when we have this posterior compressive strategy, you're going to get an anterior orientation of the thorax. You're going to get an anterior orientation of the pelvis. You have to reorient that first. So that's creating that posterior orientation, right? And then creating the expansion. So when we talk about expansion on the back side of the pelvis, especially we have a great representation of that in the sacrum with counternutation. So I need to be able to recapture counternutation. Well, but that requires that I reduce the anterior orientation first, because when the pelvis anterior orients or when the thorax anterior orients, everything's moving as a single unit. I no longer have relative motion between the scapula and the thorax or the ilium and the sacrum. So I got to get into a position where I can start to recapture that first. So first strategy under all of these circumstances is creating the reorientation where I'm no longer using the anterior orientation, which is an IR position, right? So IR, you probably heard me say this, is that internal rotation is a downward force, right?
Yeah. Yep.
Okay. So that means that the pelvis has to dump forward and push down. It's like I got to rotate it back so I can expand upward. Does that make sense?
Yeah. So would that be something like, depending on what the person can tolerate, would that be something as simple as having, so like in a quadruped position, if someone can kind of dissociate the pelvis into like a lumbar specific cat-cow and then breathe into that, would that
you got to be really, really careful with, you got to be really, really careful with that type of an exercise, because there's a tremendous amount of substituting that can go on there. Right. So if you get somebody that is just bending the spine, so think about somebody that's using a rectus abdominis to pull a sternum and a pubis closer together, that would be the exact wrong thing to do.
Okay.
All right. So what you want, the way I always describe it to people is, imagine you got on your favorite pair of blue jeans and somebody's grabbing a hold of your back pockets and pulling down on them. That's the direction that we're talking about. So it's not pinching. It's not pinching the glutes together as if you're trying to hide a quarter between your butt cheeks, right? So it's never that kind of a squeeze. It's a posterior orientation. So what you got is and if we wanted to talk about musculature, you've got some adductor activity along with the posterior hip musculature that's going to create this posterior orientation. Okay. Right. So you could do this in any number of positions. You can do it you can put somebody's hands on a chair and teach them how to do it in standing. You can lay them down. You can put them in a hook lying position. You've probably seen my cross connect video. You can do variations of that. All of that stuff is going to start to bring the pelvis into its posterior orientation. Okay. Got to do that first, because I got to create a position where the sacrum is free to turn. And if I am compressed and anteriorly oriented, there is no sacrum turning. The pelvis is turning as a single unit under those circumstances. No relative motions available in the pelvis.
Okay. So with the sacral position, when you're trying to determine what that is for an individual,
yes,
is part of that coming from their ISA position?
Yes.
And then secondary to that, do you use the position of the lumbar spine as well to give you an indication as to what that new patient is going to be? So if someone is like hyperlordotic or a little bit flatter through the lumbar, in addition to the ISA measure?
Okay, so let's just talk about one at a time. How about that? All right. So my IPA and my ISA are reflective of one another, right? So when I get a wide ISA individual, I got somebody that's biased towards the wide IPA, right? And so this is the innominate bones being internally rotated on a nutated sacrum. This is no turn land, right?
Right.
This is actually where I'll find a lot of my high performance people, because they need to create such high forces and pressures into the ground. I don't want to dissipate the force. I want to magnify it, and so then they use this position a lot. So when you get a wide ISA individual in your office, this is your representation. So what's going to go with this is, if I've got a nutated sacrum, what I'm going to see is more internal rotation produced in the lumbar spine. So that would be traditional representation of extension. So anything that's extension is internal rotation, right? So I see a magnification of that. And so I can make some predictions off of that one simple measure of the ISA and say, okay, this individual is going to be biased towards certain strategies, and then I can start to work from there. Does that answer that question?
Yes.
Okay.
Yes.
Yeah. Because so sometimes there's things that you're going to be able to see that are visual, and they are supportive of your findings, and then there's sometimes where you just can't trust your eyes. Okay.
Yeah.
Under most circumstances with the nutated sacrum, you're going to see an IR lumbar spine.
Okay.
Okay.
Yeah, because it's just in a couple of the videos, you kind of when you're answering these people's questions, you kind of come back to I kind of forget how you refer to it, but basically in a perfect world, in terms of what you would expect to see with a wide or a narrow ISA at the extremes. So I was just curious if you had any secondary measures that you use to try and confirm what you expect, with regard to the sacrum, for example.
Sure. Well, okay. So let's just build this out a little bit as far as expectations go. Right. So under any normal circumstance, if I have a nutated representation of the sacrum, I have an ilial representation that's going to follow. So the ilium are going to be IR. That brings the innominate into IR. Okay. And that changes the orientation of the acetabulum. So the acetabulum is going to move up and forward. So that's an inverted representation of the acetabulum. So my expectation there is I'm going to pick up some internal rotation capabilities in the hip, and I'm going to lose some ER representation. So, okay. So right away, I have this foundational representation of what I should expect structurally as far as their bias is concerned. And remember, it's always a bias, because both ERs and IRs are always there. It's just how are they producing them, right?
Right.
So if I have, somebody that, and again, you'll never see this guy, so, but I'm using it as a representation. If I have a wide ISA individual that has full breathing excursion, I might see a bias towards a little bit more internal rotation and a little less external rotation, but he's still going to have some pretty decent movement capabilities, where you're going to approach like the total motion representation is probably going to be about average.
Yeah.
Right. And so again, it's like you got to consider that guy. Like I said, we never get to see him because we don't see those people that have full movement capabilities, because when they do, they tend to feel pretty good, right?
Yeah.
Yeah, exactly. But at least you can start to create the bias. And so then this is going to translate up into the axial skeleton and down into the feet, because it has to, because I've got these iterative aspects to anatomy. So the upper thorax and the pelvis tend to behave the same. The foot is going to be oriented in a certain way based on center of gravity. And so I have a center of gravity shift that's associated with the nutation, right? So that's going to drive my center of gravity forward. So I should expect to see the arch moving down towards the ground as they're translating the tibia forward over the foot. So again, it's like you have these nice little representations. Now, there's a lot of other strategies that can be superimposed on that, but at least we have this foundational representation from which we can start to work. And we say, okay, this guy started in middle propulsion. So he's like literally right over his feet. And then I shifted his center of gravity forward. What should my expectations be under those circumstances? And then that's where you start to see the changes in the average ranges of motion start to disappear. When I start to get superficial stuff laid on top of this, we're going to start to lose more and more ranges of motion, because we've taken away turns that we need to create these ranges of motion.
Right.
Okay? Does that provide you an element of understanding? Because I know I'm talking fast because we only have a little bit of time.
Yeah. No, it gives me something to go off of for sure.
Yeah.
Yeah. Yeah.
And then, your narrows would be the opposing strategy. So they're going to be the ER bias. They're going to be the retroverted acetabulum, right? And then you're going to see early or late representations, depending on how far they are into these strategies. They're going to be biased towards ERs.
Yeah.
Yeah. But does that help you?
Yes.
Okay.
Yeah.
Okay.
Yeah.
Good.
Yep. That'll
We
give
got
me a
2
little
minutes.
more.
We got 2 minutes.
2 minutes. Okay.
Yeah.
So I guess my next question would be actually more with regard to assessment, and this can be quick, but like I know you've mentioned Diane Lee in previous videos about her thorax and pelvis.
Yeah, she's got great. The books are great for the mechanics.
Yeah.
Yeah.
And, at a previous clinic I worked at, a number of the practitioners had done her integrated systems model training, and they kind of used that. So her big thing is trying to find the individual's driver that influences their task. So I was wondering for you, how caught up do you get in a person's injury history and things like that, with that kind of guiding your assessment or your treatment, or do you just go off what you see and what you find and see how you can influence that?
Yeah. So the injury history can provide you a little bit of an understanding of a previous strategy. There might be a constraint change that's an influence. So as soon as you change a constraint, you have now just altered the movement options. So it's always a factor, but ultimately what you're gonna use for your primary frame of reference is if you do table tests, you're gonna use your chessboard that you're measuring off the table.
Mm-hmm.
And that's going to be what you're going to use to make your first decisions, your interventions, and then determine what your KPIs are going to be, right? But again, if I had somebody that came in and they said, "Well, I had a bank cart repair, and I never got my shoulder motion back," it's like, okay, I got to start thinking about that as a possible change in constraint that's now going to influence every decision that I make. So it's always on the table, so to speak, to make a pun. Yeah. It's always on the table. Right? It's always in the back of your head. You just have to decide how important it is.
Right.
All right, young man. We are officially out of time.
Okay.
Great to meet you. If you got another question, let me know. We can always set up another one. Okay.
Okay. Thanks so much.
All right, man. Have a great day.
You too. Bye for now.